Great. Well, good morning, and thank you for the opportunity to discuss depression and testosterone. These are my disclosures. So I want to put this in perspective. So depression, a worldwide phenomenon. Up to 5% of men and women in the world suffer from depression. But if you look at the prevalence of depression in the United States, men and women above the age of 65, that goes up to 8%. And look at the economic burden of depression throughout the world. $83 billion we spend on depression in the United States every year. But when you look at depression in sexual medicine conditions, that number skyrockets. If you look at sexual medicine in terms of Peyronie's, the prevalence of depression is 48%. If you look at depression for ED, at least 38%. Premature ejaculation, 33%. Female sexual dysfunction, 59%. And hypogonadism, 92%. So clearly, in what we do in a day-to-day living, many of the patients who present to us also have depression, many times from the condition they're presenting with. And realize that 92% of men have some degree of depression when they come in with hypogonadism. So we have to ask ourselves, look at the two conditions, hypogonadism and depression. There are many shared conditions: low libido, low energy, decreased work performance, poor concentration. So when that man walks into your office with low energy, low libido, poor concentration, you're typically thinking this patient's hypogonadal. Why? Because we're urologists, and that's what we think. But maybe this man's also suffering from depression, or maybe this man's also suffering from both conditions. We have to put depression in the back of our mind as a potential diagnosis for many of these patients that are presenting to us. So the question I want to ask today is two. I want to first ask, does low testosterone increase the risk of depression? And second, if I give a man testosterone, does that improve depressive symptoms? So let's look at the data. The data is very clear. Numerous studies have demonstrated that men with low testosterone levels are much more likely to suffer from depressive symptoms. In fact, there was a wonderful study by Molly Shores many years ago that showed that there was a linear relationship between testosterone and the incidence of depression, suggesting that those men who are more severely hypogonadal are much more likely to suffer from depression. In a registry study that we published in 2012, we looked at 849 men who were hypogonadal, and we gave them the PHQ-9 questionnaire, which is one of the most validated questionnaires for depression. We followed these men for 1 year. At the end of 1 year, we had 233 men who had a testosterone level and a PHQ-9. And what we found was that roughly 92% of men with low testosterone suffered from some degree of depression. 92% of men had some degree of depression. And in fact, roughly 17% of those men suffered from severe depression. After we treated these men with 1 year with testosterone, severe depression dropped from 17% down to 2%, and the PHQ-9 score had a reduction from 8 down to 4. Now, if you haven't used the PHQ-9 questionnaire, it's important to realize that in order to be clinically significant on the PHQ-9, you have to have a 50% reduction in where you're starting. So in other words, if you start at 10, it goes down to 5, or you have to have a reduction by 5 points to be clinically significant on the PHQ-9. Now, yes, this registry did show that maybe it's favorable to give testosterone to men and it may be beneficial, but this is a registry study, and there are many biases and limitations with a registry study. So what do the randomized placebo-controlled trials say about giving testosterone and improving depressive symptoms? Well, the results are mixed. If you look at randomized placebo-controlled trials, some trials show that there may be some benefit in giving testosterone and improving depressive symptoms, but it's typically only a modest benefit. Other trials show no benefit at all. But if you look at the last 10 years, there have been two large trials, the T trials and the Traverse trial, and I want to show you the results from both of them. So the T trial was 790 men over the age of 65. They had to be hypogonadal, and they received testosterone gel or placebo for 12 months. This trial was composed of 3 sub-trials, one of them being the Vitality trial. In the Vitality trial, the outcome was fatigue, primary outcome. Secondary outcome was also fatigue, but also the SF-36, which is looking at quality of life. And then looking also at the other two, which is associated, the first one's the PANIS, which is associated with mood. And then again, once again, the PHQ-9, which is associated with depression. So let's look at the results. If you look at fatigue, there was actually no benefit in fatigue in giving men testosterone over placebo. But if you look at the other secondary outcomes, looking at actually quality of life and also looking at the PANAS and the PHQ-9, there was a statistically significant improvement in mood and in depression in these patients receiving testosterone. The problem is, if you look particularly at the PHQ-9, the difference in that was roughly 0.72. So that may be statistically significant, but if you remember what I told you about, this is not clinically significant because that difference is very small. And then let's look at the TRAVERSE trial, the largest randomized double-blinded placebo-controlled trial ever performed. Men were between the ages of 45 and 80. They had to have cardiovascular risk factors or they had to have cardiovascular disease. These men were hypogonadal. There were 5,246 men in the trial. The mean duration of treatment was 22 months. Mean follow-up was 33 months. So in this trial, one of the 7 sub-trials was the depression trial. And they divided these men into 3 groups. All men who were defined as having depression by the PHQ-9, or men who met a criteria for low-grade persistent depressive disorder. We call that LGPDD, which is also known as dysthymia. The outcomes were to just look at the incidence of depression in these groups of men, and also to see if they had an improvements in depression, energy, sleep, and cognition as defined by the HISQ questionnaire. So what did we find? So in this study, 51% of men who presented with low testosterone had some degree of depression. Pretty significant. 51% of men who presented with low testosterone had some degree of depression. And with testosterone replacement therapy, there was a statistically significant improvement in mood and energy, but no improvement in cognition or sleep. Now, although it was statistically significant, the difference was very modest. When you look at the subgroup of those patients defined as having LGPDD, there was no significant difference in those men receiving testosterone versus placebo. So, how do we conclude? First, we know that many conditions in sexual medicine are strongly associated with depression. We also know that depression and hypogonadism share many common symptoms, and men presenting with hypogonadal symptoms should be screened for depression. Remember what many of us do in our practice. A man comes in, he's hypogonadal, his level's 250, we raise him to 500. He comes in, he still has symptoms. We say, he needs more testosterone. We raise him to 800. He comes back in, he's still hypogonadal. I want you to stop for a second and think, maybe this man's depressed. Depression has to be on your differential when these testosterone supplementations are not working. Numerous randomized placebo-controlled trials have demonstrated low testosterone is associated with depression, and testosterone could result in a modest clinical improvement in depressive symptoms. And finally, in the more recent T trials and the TRAVERSE trials are consistent with demonstrating the association between testosterone levels and depressive symptoms, but only a modest clinical improvement was seen in depressive symptoms with testosterone therapy. Thank you for your attention.